We would now be progressing ahead with the eco quiz that will be moderated by Dr. Gupta, which would be for the span of 40 minutes. With his permission, I'd like to invite the members of the expert panel, which comprises of Drs. B Vijayalakshmi, Asha Murthy, A.K. Omar, Manish Bansal, R. Mehrotra, Vinayak Agarwal, Divya Malhotra, Sonia L. Saideh from Egypt, and Hala L. Marsafavi from Egypt as well. I would also request Dr. H.K. Chopra and Colonel S.K. Parashar to join the other panel members on the dais. It's over to Dr. Gupta. Thank you.
Okay, good afternoon again. Till now you have been listening to us. Now we are going to ask you a question also. And that's what the eco quiz is. I have with me Dr. Hala, Dr. B Vijayalakshmi, Dr. Ashok Kumar. Can I request my colleague Dr. H.K. Chopra and my senior for the father of echocardiography? The international father of echocardiography, Dr. Naveen C. Nanda, on a dais, please, sir. No echo quiz is possible without you. That's what I say. So first of all, I'll invite Dr. B Vijayalakshmi to do her presentation. And Dr. Vijayalakshmi, I'll suppose that you are going to ask questions to everybody in the audience. Not from a dais people, you know.
And please don't frighten with the complicated questions.
Respected chairpersons and dear delegates, you know, Rakesh told you that how difficult it is to keep the people awake after lunch. It's very difficult. When I was a student, I was very mischievous. And once when I entered the class, the blackboard was so beautiful. And then it was so tempting. I wrote on the board how to get along in the class. Sleep, but do not snore and wake up the others.
I'll share one more joke. I always used to sit in the front, you know. It's not that I was a good student, but I looked at the time when the teacher will go away and I'll occupy his chair.
Echo quiz is the real hallmark of any conference because it's a case-based presentation and is of a great clinical value and application for us to manage our patient very meticulously. And the cases shown are of a great interest. So I am sure Dr. Vijayalakshmi has a lot of material and she will show some light on very, very important aspects of clinical cardiology as well as pediatric cardiology, which she is trained in. Vijay?
Yeah, this is 55 years old male who was a diabetic for past 15 years. He was brought to the hospital in a state of cardiogenic shock. So you know the conditions causing the cardiogenic shock. With a history of severe retrosternal pain, profuse sweating, vomiting, orthopnic, and the patient was orthopnic, the limbs were cold and clammy, the diagnosis is there, the pulse was 120, thready, the BP was 60 by 40 millimeters of mercury, bilateral creps. So emergency echo was done and this is the echo. What's the diagnosis? Patient is very sick, emergency echo is done in the ICU and this is the diagnosis. What's the diagnosis? Anybody?
She could do the echo. The clue is.
Anyone? Yeah, I think You would like to make the comment, sir? No, not, not for you, it's for the adult. Yeah, I think Asha is going to tell you the diagnosis. Use the mic.
Age? What is the age?
55 years old.
It's a ventricle septal rupture.
Yeah, this is a free wall rupture. And
With left to right shunt.
yeah, I mean we don't call it as a shunt in the true sense. If there is a rupture in the interventricular septum, we call it as a shunt, but not when there is a free wall, because the shunt has to go somewhere. Here it's not going. So this is a very real crisis. Yeah. Hala wants to make comment.
Please use
Switch
the
on
mic.
the mic.
Sorry, this is for old patient.
55 years old patient, diabetic, came with a severe chest pain in a cardiogenic shock. So this is a free wall rupture, and you know it is really difficult. So this is another 55 years old patient, again diabetic. He had acute antwall MI and he reached to the hospital very late. Whereas the first patient came very early, this patient came very late only after he had a cerebrovascular accident, and he was brought in a stage of semi-coma. And what you see in the echo?
You see a elongated thrombus in the apex.
Yeah, what you see is a very, very soft, mobile thrombus, which is almost like, you know, moving like a parda. It's like a membrane. It is so soft. So why this is important is, one, with the cerebrovascular accident, you don't give thrombolytic therapy. Two, even if the thrombus has embolized, some part of it may be still there. So here the thrombus is still there in the left ventricle, and this is the patient should not be thrombolized. Otherwise more thrombus will embolize into the cerebrovascular system or the peripheral system, and then it could be more catastrophic, and the white thrombus will become red, the white infarct will become red infarct, and the patient will become worse with thrombolytic therapy. So this is the true contraindication for thrombolysis in the presence of acute MI. This is an 8-year-old boy who had a bluish discoloration, the cyanosis right from the birth. No history of squatting, facial puffiness was there, then swelling of the limbs was there, abdominal distension, cough for the past 15 days. And this is in the subcostal, you are seeing the inferior vena cava and the hepatic veins.
TAPVC infradiaphragmatic with scimitar representation.
No, TAPVC does not cause cyanosis from day one.
As an inferior wall with obstructed veins.
Yes, what you notice in this dilated, Hala would like to comment? Sanya? Yeah, IVC is dilated, non-collapsing, that's right. Anything? You see a spontaneous echo contrast in these veins. You can look, the air bubbles are moving. That is the spontaneous echo contrast. Where is the pointer? The spontaneous echo contrast, like how you see the sec in the left atrium, you are seeing in the IVC. If you see a sec in the IVC, you must always think of pericardial effusion with tamponade, constrictive pericarditis, restrictive cardiomyopathy, right-sided heart dysfunction, pulmonary hypertension, right inflow absent, and the tumors or thrombus or AV fistula. And sec in IVC always indicates there is an impaired flow or the stasis of the flow in the inferior vena cava. And when we did the echo, this is what we saw. What do you see now? Sanya? Yeah, switch on the mic and then you can speak. Yeah, switch on the mic.
Pericardial effusion.
Yeah, there is a pericardial effusion. More than that? You can notice that.
Localized.
No, there is a big tumor in the AV group. There is massive pericardial effusion and there is a mass in the AV group. So mesotheliomas are the ones which give rise to the thing. But in this case, we didn't know what it was. We went ahead. See, don't be happy with one view. And one thing with congenital heart disease is always like birds of the same feather flock together. You have multiple anomalies. Just because you have got a dilated IVC, you have got a pericardial effusion, you have got a tumor, don't be happy and see what is this. There is a non-compaction. This is called as the spongy myocardium. You can see that there is a sponginess or the non-compaction of both the right ventricle as well as the left ventricle. So already the patient had a pump failure. On top of that, pericardial effusion and the tumor had occurred. But this does not explain why the child was cyanotic right from day one. So when we went ahead and did the other,
To see some color flow on this non-compaction.
pardon?
Color flow on the
Yeah,
myocardial island.
Hala is asking how to make out the non-compaction and the echo. There are 4 criteria. One, the hypertrabeculation of the left ventricle, right ventricle, the compacted layer to the non-compacted layer, the ratio must be more than 2:1, and then apart from that, the blood must be flowing with the color Doppler into the trabeculae, and there could be a Swiss cheese IVS. So those are the features, and when we did a parasternal long axis, you can see that. Can you tell the diagnosis now?
Dr. Parashar?
Pardon, sir? Yes, sir. Yes, sir, correct. But Parashar is adding up that it should be more than 15. Okay. Pardon?
Use the mic, please.
This patient has congenital heart.
Yeah.
Is congenital double outlet right ventricle?
Yeah, this is the double outlet right ventricle. You can see that the aorta is anterior and the mitral to aortic continuity is not there. There's a discontinuity from the thing. You can see that this is the mitral valve and this is the pulmonary valve with the stenosis, and that is the aorta. So both the great arteries are coming from the right ventricle. So this patient's complete diagnosis, congenital cyanotic heart disease with double outlet right ventricle, with non-compaction of both the ventricles, with tumor in the AV groove, with pericardial effusion, with IVC flow obstructed.
And
that's
pulmonary
the complete
stenosis.
diagnosis.
He has pulmonary stenosis too.
Yeah,
Okay.
that's true. So this is a 19-year-old boy who came with after the road accident. He was treated for fractures elsewhere, and then he developed acute breathlessness. Whenever a young person after the accident develops acute breathlessness, the first thing that everybody thinks of is the pulmonary embolism. But this patient does not have pulmonary embolism, and this is the echo. What is the diagnosis? I think Dr. Parashar is going to tell the diagnosis here.
Ventricular rupture, ventricular aneurysm. He has
No, there is no
post-traumatic-
ventricular aneurysm. No.
Is there any other view?
No, this is the only view and this is the most diagnostic view. Anyone? Parashar Sarji?
What is this view first? This is a 4-chamber view or
Yeah, this is the left ventricle and that is the huge thrombus occupying the whole of the left ventricle. See, usually unless there is akinesia or hypokinesia or infarction, the thrombus does not occur in the left ventricle unless there has to be dilated cardiomyopathy or stasis, something. If according to Virchow's law, either there has to be endothelial abnormality or the sluggish flow or hypercoagulability. But in this patient, none of them were there. It was just a road accident and then patient did not have any MI, and this is extremely rare condition where in situ the left ventricle huge thrombus occurring in a young person, extremely rare case. Yes, sir? No, sir, this is T. I just took one. Yeah. Yeah, we did the 2D and we were not sure what the diagnosis. We thought maybe myxoma, but then we did the T. This patient underwent surgery and the histopathology came as the thrombus.
Why? Why do you think he has it?
Pardon?
Why should he have a thrombus?
no? Maybe patient is having pre-existing CAD itself.
No, 19 years old,
possibilities
it's unlikely. So we don't know. He had a normal coronaries, normal wall function,
So
everything normal. We made it as a myxoma and then sent for surgery, but a histopathology came
So he
as
arrested,
thrombus.
he arrested before he was saved, or he arrested for a few minutes.
Hypercoagulous.
No, because of accident, maybe injury or something, we don't know. I mean, it's all hypothetical and we cannot tell. But histopathology proved it as thrombus. Yes, sir. Yes, sir. Give the mic. No, I also had not seen, sir.
Mike,
You're
please.
right.
Mike.
So we had a lady about 35, 37 who came with a recovered cerebrovascular accident.
Correct.
We did a echo. There was a thrombus at the LV apex. And there was an involved microstenosis with regurgitation, and she turned out to be hypereosinophilic syndrome.
Oh.
So hypereosinophilic syndrome is another cause of an LV thrombus, and that lady ultimately they go to the restrictive cardiomyopathy. So besides the other causes which you have said, possibly always think of it. And if you see literature, hypereosinophilic syndrome has been cited as one of the causes for mitral stenosis.
So before sending for surgery, the patient was evaluated completely, including the cardiolipins. He did not have any.
No, I'm just telling you one more cause we had.
Yes, sir. Agreed, sir. Point is well taken, sir. Shall I finish it?
Yeah, yes.
Yeah,
I
thank
think,
you very much for your
The next
patient
position,
hearing. Thank
Sonia.
you.
You have your presentation.
You know, maybe she
Okay. Hala.
they were preparing a couple
Okay.
of systems.
Not about something. Omar, you have a case? Okay. Naveen, you have to show something? After Hala. You have to show something, Asha? Are you showing something?